evening, everyone. I am Olalua Ezekiel Dada. I am a second-year medical student from the University of Ibadan, Nigeria. I'm also a research fellow at the Association of Future African Neurosurgeon. I'm also a member of the Operation Department. Glad to be here today for today's webinar on the Neuro-Oncology Course. And I would like each and every one of us to present ourselves. And Danny, can you present yourself?
Hello, everyone. My name is Danny Kambode. I'm a fifth-year medical student, Copperbelt University, Zambia. Thank you so much.
Okay, thank you, Danny. You're welcome. We're glad to have you here. Emmanuel, can you go ahead to present yourself? Emmanuel Mukambo, can you please present yourself? All right, Dr. Daniel Safari, please present yourself.
Hello, everyone. Good evening. I'm Dr. Daniel Safari from Democratic Republic of Congo. I'm glad to be with you this evening. Okay.
Thank you, Dr. Daniel. You're welcome. Dr. Nuru, unmute and present yourself.
Hi everyone, I'm Dr. Nuru from Korea. I'm chief resident in the Biophysics Lab Training Center in Morocco. I'm glad to be here with you this evening. Thank you.
Yeah, thank you, Dr. Nuru. You're welcome. Dr. Chibuike, unmute and present yourself.
Hi everyone. I'm Chibuike Mkwibwing from Lagos, Nigeria. I'm happy to be here.
Thank you, Dr. Chibuike. You're welcome. Dr. Francois, can you please unmute and present yourself?
Hello, everyone. I am Rutaisre Francois Xavier, a doctor from Rwanda.
Thank you. Rachel, can you unmute and present yourself?
Hi, everyone. My name is Rachel Mpokota, a second-year medical student at Levi Mwanawasa in Zambia.
Thank you. You can go ahead with your presentation. You can share your screen.
Okay. Just hold on a bit.
All right.
Okay, so a 61-year-old female presents with 10 weeks of progressive blurring of vision and headache. The BMI shows that it's unremarkable, and then the exam shows that the extraocular movements are normal. The visual acuity has worsened from the time of the recent ophthalmological exam. Bitemporal visual fields are defective, and other aspects of the exam seem to be normal. So, what can be our differential diagnosis? I'll allow for people to comment. So under the neoplastic, we have pituitary adenoma, we have meningioma, we also have craniopharyngioma, the optic pathway glioma, the hypothalamic glioma, and then under developmental, we have the Rack's cleft cyst, we have arachnoid cyst, then we also have the vascular, excuse me, we have the vascular. Under that, we have the giant aneurysm, carotid cavernorism, and then we also have infectious / inflammatory, where we have the pituitary abscess, Langerhans cell cystosis, and sarcoidosis. So, what do we think? How best do we think we can narrow these differential diagnoses? To what can we narrow these differential diagnoses to? I'll allow for contributions. You can just tell me your thoughts and we have to discuss. So, yeah, Anyone? It's a discussion, so we're supposed to be sharing information. Okay, so Ezekiel, what are your thoughts on the differential diagnosis? So what can we narrow it down to?
I have no idea actually.
Okay, Mr. Daniel.
I do think we can go for neoplastic process, and if it's a neoplastic process, then I will go for an optic pathway glioma first, and then I'll try to exclude an hypothalamic glioma. If we can consider other differential diagnosis, I will go for vascular, and then I will exclude a giant aneurysm.
Okay.
And in the infectious or inflammatory process, I will exclude a pituitary abscess.
Okay, thank you, Daniel. So why you choose optic pathway glioma and hypothalamic glioma? Why you choose directly glioma?
I choose directly glioma regarding first the age of the patient, and optic pathway glioma because all the optic nerve are interested.
Okay, but you know that here you have a bitemporal hemianopsia.
Yeah, a bitemporal hemianopsia. So I can also exclude posterior fossa tumor or neoplastic process, but it's not among the diagnosis here.
No. Look, I am agree with you what you carry out like a diagnosis. Here you have what we call an optochiasmatic syndrome. So that means what? That means that it is your cellular region who is involved. And if you just have only blurred vision loss without bitemporal hemianopsia, yeah, I am agree with you that you can go for directly optic path nerve. Here it is something who compress the optic path, but not from optic pathway. I don't know if you understand my point. So when you have
I don't understand.
Okay, when you have optical chiasmatic syndrome like bitemporal hemianopsia with loss, blurring vision loss, okay, you should think about optic chiasmatic syndrome. And when you have optic chiasmatic syndrome, you should think about the stellar region. When you remember your anatomy of stellar region, you have what? You have pituitary adenoma. Yeah, and you have a sinus cavernous sinus. You have then what you have then on the pathway. You have a pituitary gland. You have then what? You have then your chiasma optics. You have your chiasma, and then you have your two nerves optics, and laterally you have your carotid carotid arteries. So what I want you to know is what when you have this syndrome, that means that you have a compression about your chiasma optic nerves. So you should think about some process who will compress that. So which region is very adequate to have to give you this compression? It is the cellular region. I don't know if you get my point. So you
I'm
should
getting
think
your point,
about,
yes.
yeah. So I agree with you if you say hypothalamic glioma, and then you could not exclude pituitary adenoma or meningioma adenoma or cranopharyngioma. Okay, you can, and then when you take the age, you might not suggest cranopharyngioma because you know that it is not at this age you will have cranopharyngioma, and maybe meningioma or maybe pituitary adenoma or maybe hypothalamic glioma. And then if you go for the developmental, yeah, I agree with you. You can suggest some RAC cleft cyst, and for the vascular, yeah. But for vascular, in my opinion, you may. It is not commonly to have giant aneurysm who give you optochiasmatic syndrome, but you can have that sometimes when you have giant aneurysm of carotid ophthalmic artery. Yeah. So I am agree with you, and about the fascials, yes, we can. You can suggest pituitary abscess. So always think about your clinical and try to find the region in the brain who will commonly give you these signs. You should do clinical anatomical relationships between your syndrome and then your region who will be involved. So I don't know if you get my point, guys.
Yeah, we got
Yes,
it.
you do.
Thank you.
Okay, great. So you can go ahead, Rachel. Thank you.
Okay, thank you for your participation. So that's the imaging seen an MRI and the scan. So it reads the actual and the carotid MRI demonstrate a large cystic contrast enhancing mass arising from the cellar. We heard our brother talk about the cellar region. I'm sure he mentioned part of it, if I'm not mistaken. And then it goes on to read the optic chiasm is not distinguishable. That means there's a disturbance in how the normal optic chiasm is supposed to be. And I heard one of you mentioning about the optic chiasm in your discussion. So it goes on to say the third ventricle is obliterated and obstructive hydrocephalus is evident in the lateral ventricles in the figures there. I don't know if you're able to see. Is everybody able to see?
Yeah, go ahead. Yeah.
Okay, thank you. So those characteristics are demonstrated. So we talk of the optical chiasm being undistinguishable, the third ventricle obliterated, excuse me, and the hydrocephalus is really evident there. So the differential there is now narrowed to craniopharyngioma, bronchitis cleft.
So here you agree with us that we have a cellular,
yes.
a cellular and a supracellular lesion.
Yes, we have those which you mentioned, I'm sure, right?
Yeah. Okay.
Yes.
Okay.
And also
Please,
have
guys, be interactive. Don't worry. You can say anything it is not right, but don't worry. Go ahead, be interactive with us. Okay.
Okay. So there's also the optic chiasm which you mentioned. So like these the scans narrow the diagnosis to craniopharyngioma, bronchitis cleft, so this. We have also the lymphocytic lipophysitis. So we're asking Ezekiel to move to the next page. Okay, I think that's just a larger view of scan. So further workup. can, next page, please. So the further workup, laboratory-wise, electrolytes and pituitary hormones, prolactin, thyroid-stimulating hormones, follicle-stimulating hormone, and the growth hormones and the like. Under imaging, we have the MRA of the brain with or without contrast. For more evaluation, then we have the visual field consultant. Through consultations, we have endocrinology, medical oncology, and ophthalmology. So using this further workout, are we able to reach to a conclusion of what the diagnosis is? So are we able to further narrow down the diagnosis using these?
Yeah, what do you think, Rachel, about the further workup? What will you do?
Okay, for me, under imaging, I'll check how the stellar and parastellar region look like. I'll check for the optic chiasm, which obviously is still there. And then under the pituitary, let me just say the endocrine. Under endocrinology, I'll check the levels of the hormones in the body. Under ophthalmology, I'll check how the optic chiasm is working, how the eyes are, the vision, how bad is it, for how long has it been blurry, has it been degenerating as time goes by. Those are the key features I'll look for under my further workup.
Okay, thank you. What do you think, guys? Are you right with her? Ivan Wanyon, are you there? Okay, Daniel Yamba, go ahead. You want to say something?
Actually not.
Okay, so what do you think about? Are you agree with her further workup?
Yes. For electrolyte, pituitary hormone, prolactin, TSH, FSH, ACTH, and GH. And for the imaging, MRA, yes, hormone evaluation, the visual field, yes, consultant, endocrinology, medical oncology, ophthalmology. I will go for ophthalmology and medical oncology.
Okay, thank you very much. Yeah, great. Go ahead, Rachel.
Okay, no one else wants to talk a bit?
Yeah, go ahead.
Okay. So we can move to the next page. Mr. Ezekiel. Okay, so here we have the pathophysiology. So craniopharyngiomas Thank you. So craniopharyngiomas are rare, histologically benign tumors that typically arise in the suprasellar region. So one of the points that our brothers talked about is there. So I hope we're pinning down the information discussions we've had beforehand. It is. Okay, so Thank you. So the exhibit a bimodule age distribution. So that was somebody that talked of okay. I don't remember exactly, but they say it can't be that because the lady was 61 years old. So this one has two age ranges in which it occurs, the craniopharyngioma. So we have the 5 to 14 being the children age range, and then we have the 65 to 74 being the adult age. And then it's not selective with gender. It occurs both male and female, like almost exact percentage. So they usually have symptoms. So they have symptoms related to the mass effect and endocrine disruption. So children either often display disruptions in puberty and or growth, and adults often suffer from diabetes insipidus. Due to the proximity of the craniopharyngiomas to the optic apparatus, visual loss is a very common complaint. It occurs in half of all patients, and craniopharyngiomas near the third ventricle can cause obstructive hydrocephalus if mass effect becomes marked. So I'd have loved us to go back to the previous slide. Thank you. So that on our further workup, it talks of electrolytes. So we have the pituitary hormones, prolactin, all those hormones. I'm sure you're able to see have the growth hormone. So I think I'll put those under endocrinology. So the endocrine system's function is kind of disrupted. So due to that, we see how it affects the growth of children. We have all those endocrine related symptoms. Excuse me. It is in very rare occasions it occurs that children have precocious growth where they grow faster than they are supposed to be. You see a 13-year-old and they look way older than they're supposed to be. And also have maybe impotence due to imbalance of hormones. And sometimes the endocrine system can be overworked where we see maybe it's very rare though, we notice obesity. Sometimes it's due to this that the endocrine system work is more than it's supposed to be. So can we please go back to the next? Oh, before we go, is anyone else to say anything? Okay. So these tumors, the craniopharyngioma, are graded in different ways, and this is dependent on the location in the areas. So the tumors are graded in several ways by histology as adamantinomatous or papillary form. So according to their relationship to the optic chiasm as pre-chiasmatic, subchiasmatic, and retrochiasmatic, and in relation to the stella as intrastellar, suprastellar, or both. So a scale grading the tumor's vertical extent has been proposed, as well as the grade 1 being intracellular or intradiaphragmatic. So grade 2 indicating a tumor within the cistern but not the stella, and grade 3 in the lower half of the third ventricle, then grade 4 in the upper half, and grade 5 in the lateral ventricles or septum pellucidum. So any comments on these, guys? So the grading of the tumor is actually important in terms of treatment, because you treat the craniopharyngiomas according to the grade of the tumors. Like, you just don't treat them anyhow. So let me just talk a bit on the grade 1. The grade 1 says it's intracellular or intradiaphragmatic. Aside that, like, it represents no hypothalamic involvement. So in the grade 1, you see how you're able to, sorry, grade 1, yeah, grade 1 has hypothalamic involvement, but then it's partial rather, sorry, it's partial. So you'll be able to see the hypothalamus, but you see that it is not the usual form. It will be distorted in terms of appearance, but it will be still there. So then the type 2, grade 2 indicates a tumor within the system, but not the cellular. With type 2, you see that the hypothalamus is completely, covered. You can hardly see it. You can't see it. So this really helps with the treatment. How hard you go on your treatment depending on the type of the tumors. So we can go to the next slide, please. Okay. Oh, okay. Please go back to the previous slide. Thank you. So I'll allow for people to comment on what they think the treatment options are. Considering we've discussed the pathophysiology, we've talked about how the optic chiasm is distorted. We've talked about how the hypothalamus is involved. We've also talked about how the visual acuity is also, which is the, yeah. So I'd like people to comment on what they think the treatment options can be for craniopharyngiomas. Okay. Mr. Shituluka, would you like to give a comment?
Actually, I don't have any comment. Yeah.
Okay, thank you. So anyone that would just give what they think can be the treatment for this case we have. We've diagnosed, we've discussed the pathophysiology, and these two can give us clues on what the treatment options can be. Mr. Daniel.
Regarding the pathophysiology of the craniopharyngioma, I do think that the treatment may follow the symptom we'll have. The patient will be complaining of. First of all, if there is a compression of optic chiasm, and if we do think that compression lead to hemianopsia, I don't think we may do phaser ophthalmologic checkup, and then we can go for surgery. On the other hand, I do think if there is a compression of the said ventricle, we can go for the treatment of hydrocephalus.
Okay.
And okay, if we do have endocrine disturbance in the patient, we can do phaser biological or endocrine examination or hormonal checkup, and then we see which hormone is deficient, and then we can give the substitute. That's what I think.
Okay, thank you. Mr. Ezekiel, your thoughts? Okay, I think we can move to the next slide. Thank you. So one of the treatment options are medical. We have biopsy, we have radiation, we have the surgical. So under medical, we have endocrine replacement. I think this was talked about by Dr. Daniel, if not mistaken. So we can have endocrine replacement tailored to the patient's deficit. So those hormones we talked about, like the follicle stimulating hormones, the growth hormones, the and many other hormones that are in deficit can be administered. Though this one, there is a debate whether this can be long-term. For instance, like the growth hormone can be administered and say the height of the person will stay constant for some time, but the long-term effects are not really known. It's not known whether the endocrine replacement will sustain the height or the growth for a very long time. So we also have the corticosteroids to reduce cerebral edema. We have osmotic agents to reduce elevated intracranial pressure. Remember we talked of the patient having headache, like consistent headache. I'm kindly asking for. So we talked of the patient having headache, continuous headache. So this can be caused by intracranial pressure and has to be worked on. So it's observed and sometimes it's, like I said, it's characterized with headache, nausea sometimes, and vomiting. And this could be due to mass effect from the tumor itself, because the tumor keeps growing, keeps growing, or it could be from the hydrocephalus, which causes obstruction to the third ventricle and the other parts. So we have biopsy, so the biopsy can be useful for definitive diagnosis before radiation. So it is believed that a significant resection cannot be accomplished. Depending on tumor composition, cyst drainage may be appropriate. So talking of cyst drainage, this is where aspiration occurs, like you pull out, you drain the contents of the tumor to reduce it. So we have radiation, which is useful in adult patients with subtotal resection or tumor recurrence. Then we have the surgical, which was talked about by one, I think that was Dr. Banda. Yeah, I think Dr. Daniel talked of the surgical, which we see there. Thank you. So surgical, so we have the cerebrospinal fluid diversion may be required for hydrocephalus. We have craniotomy. We have transsphenoidal approach, orbitozygomatic craniotomy, the intrahemispheric or intracallosal craniotomy, and those others. And if you remember, I talked about the types of craniopharyngioma, the degrees or the types rather of craniopharyngioma, and this is where they are applied. Like each of those surgical processes follow the degree and type of the tumors. So do we have any comments on the treatment options? Would anyone like to talk a bit?
Yes, I've got a question.
Okay.
Yes, since a patient presented with headache, and you said
Yes.
one cause of the headache could be elevated intracranial pressure, and you gave some of the management options like the osmotic agents and the CSF diversion. Now, could there be any other causes of headache in these patients apart from the elevated intracranial pressure? Yeah, that's my question.
Okay. Okay. Any comments from the group? Okay. Okay, so I'll give my thoughts and I don't know other people will comment. So this tumor keeps growing in the in the cellular region. So I think there may be other causes of the headache because it's growing, it's disturbing. Like for instance, the ventricle, the third ventricle, for instance, is disturbed. We have the optical chiasm, we have chiasmatic compression also. So it affects many parts. So I think majorly the cause is okay. It's intracranial pressure. So it's not something that's definite. So the intracranial pressure could come from the chiasmatic compression. The intracranial pressure could come from maybe the obstruction of the third ventricle. The intracranial pressure can come to maybe the distortion of the endocrine system. The homeostasis is not balanced. So I think intracranial pressure should not be seen as something that, not be seen as something that's definite. It should be seen as a package that holds a whole lot of distortions in the brain. So I don't know. I'll allow for other people to put their thoughts, what they think to the table, and we can discuss.
I'd say the principal cause of headache is the augmentation of the intracranial pressure, the rise in intracranial pressure as the tumor is growing. There is some structure that are sensitive. We see the basal sinuses and all the basal arteries and the meninge. They can be irritated by the volume of the tumor, and then that is the main cause of the headache in the patient. If someone has another idea, I've put a paper in the chat. It's about the main causes of headache in patients with craniopharyngioma.
Okay, thank you. Dr. Shituluka, does that answer your question? Does that lighten up the burden?
Yes, it does. Thank you.
Okay, thank you. So all you want to go through the link. I don't know if it's the link or the causes of headaches in craniopharyngioma. I'm sure we'll do that, go through it a bit later after this. Can we please go to the next slide?
Thank you, Rachel. Thanks so much for the presentation. It was really a wonderful presentation, and thanks, Dr. Daniel, for the contribution. Thank you to every other person who contributed, and much thanks to Dr. Nuru for his contribution before leaving. It's really a great presentation. Good job, Rachel. If there's no any other contribution, we'd love to call it a day. Okay, I'm all right. I'm going to end the meeting. Thanks everyone for being present. Thank you. We are glad to have you. Looking forward to catching up with you guys next week again. Thank you very much. Bye.